The A wave of jugular venous pressure or jugular venous pulse is produced by atrial systole. Curly B lines in the chest X-ray of a patient is a radiological feature of heart failure. Pulsus paradoxus can be seen in the following clinical states except acute myocardial infarction. So it can be seen in pericardial tamponade, acute severe asthma, and massive pulmonary embolism. Bibasilar velcro crackles occur in pulmonary fibrosis. A mill wheel type of murmur during laparoscopy suggests gas embolism. Giant V wave on examination of the JVP jugular venous pulse is suggestive of tricuspid incompetence. True about third heart sound is that it is heard in mitral regurgitation, diastolic sound, and it is normal in children. It is not a high pitched sound. Murmur increasing with Valsalva maneuver is hypertrophic cardiomyopathy HOCM. Positive hepatojugular reflex is found in all of the following except decreased afterload. It is found in tricuspid regurgitation, right heart failure, and increased capillary blood bed pressure. P2 is best appreciated at probably left intercostal space. Which left intercostal space? Pulmonary edema PCWP is more than 8 mm of mercury. QRS complex indicates ventricular depolarization. ECG in young healthy person with 80 beat per minute will not show none. So it will show all of these. PR interval between 120 to 200 msec and QRS interval less than 100 millisecond, and interval between 2 QRS is 750 milliseconds, and T wave represents repolarization. Current of injury is ST segment. Wolff-Parkinson-White syndrome, all true except that it is more common in female. No, it's not more common in female. So what is true about it? Right ventricular aberrant is commonly seen. Incidence increases with age, and heart is structurally normal. Incidence is 0.3 to 0.7%. All are ECG findings in Wolff-Parkinson's White syndrome except narrow QRS complex. It is not a finding. So what are the findings? Normal QT interval, slurred and tall QRS, and short PR interval. The drug of choice in patient with Wolff-Parkinson White syndrome with atrial fibrillation is procainamide. Congenital long QT syndrome can lead to polymorphic ventricular tachycardia. Torsade de Pointes is caused by hypomagnesemia. Feature of Torsade de Pointes is prolonged QT interval. Torsade de Pointes causes wide QT. Which of the following statement about premature ventricular beat is false? Prevalence decreases with age is not true. Sequential depolarization of ventricle, wide Bezier notched QRS complex, and palpitation is a common presenting feature. In a patient with wide complex tachycardia, the the presence of all of the following in the ECG indicates ventricular tachycardia except typical right bundle branch block. So what represents ventricular tachycardia? Atrioventricular dissociation, fusion beat, and capture beats. Ventricular tachycardia is represented by all except typical right bundle branch block QRS complex. So it is represented by wide QRS complex, AV dissociation, capture beat, and fusion beat. Ventricular ectopic beat represented by irregular RR interval, AV dissociation, presence of fusion beat, and wide QRS. ECG finding of ventricular premature beats, fusion beat, AV dissociation, wide QRS complex, and capture beat. Accelerated idioventricular rhythm is AIVR is most characteristically seen in myocardial reperfusion. A patient with heart failure developed ventricular arrhythmia. Treatment is intracardiac defibrillation, beta blocker, and amiodarone. After a successful total hip replacement, a 59-year-old patient developed severe chest pain. Echocardiography revealed reduced wall motion of right ventricle with slow flow across the tricuspid valve. Which of the following is most likely diagnosis? Pulmonary embolism. What is the drug of choice to control supraventricular tachycardia? Adenosine. A chronic alcoholic develops palpitation suddenly after alcohol binge. His pulse is irregularly irregular. Which of the following arrhythmia is most commonly associated with alcohol binge in the alcoholics? Atrial fibrillation. Atrial fibrillation may occur in all of the following conditions except hypothyroidism. It can occur in mitral stenosis, it can occur in dilated cardiomyopathy and mitral regurgitation. In a patient with chronic atrial fibrillation with a regular beat of 60 per minute, the most probable cause is digitalis toxicity. A person with mitral regurgitation and atrial fibrillation presents with syncope. On examination, the person has a heart rate of 55. What is the most probable cause? Digitalis toxicity. True regarding atrial fibrillation, thromboembolism, digoxin treatment, aspirin given. So what is false is that anticoagulant is not required. So anticoagulant is required in atrial fibrillation. Which of the following is seen in second degree atrioventricular block? Change in morphology of ventricular complex, increased atrial rate compared to ventricular rate, increased atrioventricular conduction time. Constant PR interval is seen in first degree block and second degree Mobitz type 2 block. All of the following are features of Mobitz type 1 block except constant PR interval. So what are the features of Mobitz type 1 block? Normal QRS morphology, regular atrial rhythm, atrial rate, ventricular rate. All of the following features can differentiate between ventricular tachycardia and supraventricular tachycardia except ventricular rate more than 160 per minute. So which features can differentiate between ventricular tachycardia and supraventricular tachycardia? QRS less than 0.14 second, variable first heart sound and relieved by carotid sinus massage. Broad complex tachycardia due to ventricular tachycardia is suggested by fusion beat, AV dissociation and capture beat. Drug of choice in PSVT is adenosine. Drug used in atrioventricular block is isoprenaline and atropine. In the treatment of severe bradycardia, all of the following can be the best modality of treatment except diltiazem. So atropine, pacing and isoproterenol is treatment of severe bradycardia. ST elevation is seen in all of the following conditions except constrictive pericarditis. ST elevation is seen in myocardial infarction, it is seen in coronary artery spasm, it is seen in ventricular aneurysm, not in constrictive pericarditis. A patient develops sudden palpitation with heart rate of 150 per minute regular. What could be the cause? PSVT is the cause. All of the following may cause ST segment elevation on ECG except constrictive pericarditis. So what can cause ST segment elevation? Early repolarization variant, ventricular aneurysm and Prinzmetal angina. QT prolongation is seen in all except digitalis toxicity. QT prolongation is seen in hypothermia, hypokalsemia and Romannoid syndrome. QT interval is shortened in hyperkalsemia. Hyperkalsemia in ECG is diagnosed by decreased QT interval. Hypokalsemia is characterized by all of the following features except shortening of QT interval in ECG. So hypercalcemia leads to decreased QT interval. Hypocalcemia will not cause shortening of QT interval. It will cause numbness and tingling of circumoral region and hyperactivity tendon reflexes and carpopedal spasm. All of the following are the electrocardiographic features of severe hyperkalemia except presence of U waves. So what are the ECG features of severe hyperkalemia? Peaked T waves, sine waves pattern, and loss of P waves. All are ECG changes in hypokalemia except QT interval prolongation. So what are the features of hypokalemia? U wave, ST segment sagging, and T wave flattening or inversion. All of the following are the ECG features of hyperkalemia except prolonged QT interval. So what are the features? Prolonged PR interval, sine wave patterns, and loss of P waves. The following ECG findings are seen in hypokalemia: increased PR interval with ST depression. Athletic syndrome is characterized by increased amplitude of QRS. Asynchronous cardioversion is given in ventricular fibrillation. In left-sided massive pneumothorax, ECG shows all except left axis deviation. No, it will not show left axis deviation. What are the ECG features? Absent R wave, peaked P wave, precordial T wave inversion. Radiofrequency ablation is done for WPW syndrome. Which of the following ECG changes is least likely in a patient with left pneumothorax? Left axis deviation is least likely. So what is more likely? Inversion of T wave, small R wave, and electrical alternance. Long and peaked A waves are seen in all except hyperkalemia. So long and peaked A waves are seen in tricuspid atresia, Epstein's anomaly, and right atrial enlargement. QT prolonged is associated with type 1 antiarrhythmic drugs and torsade de pointes. A 48-year-old presents with a history of precordial chest pain. He has blood pressure of 80 by 60 mm of mercury. ECG shows wide QRS complex with no preceding P waves and a rate of 112 per minute. The most immediate step in the management of this patient would be DC electrical cardioversion. Desynchronized defibrillation is used in ventricular fibrillation. SA node is pacemaker in heart because its resting excitability is highest of all. Desynchronized defibrillation is used in ventricular fibrillation. The current drug of choice in paroxysmal supraventricular tachycardia, that is PSVT, is adenosine. Wencken-Bach phenomena is defined as progressive lengthening of PR interval till a beat is dropped. P wave is absent in atrial fibrillation. Verapamil belong to which class of antiarrhythmic? Class 4. Which one of the following electrocardiographic changes is found in hypercalcemia? Short QT interval. Which one of the following is the ECG hallmark of hypothermia? Osborn J wave. Ventricular aneurysm has one of the following characteristic features: persistent ST segment elevation. Acute symptomatic sinus bradycardia usually responds to atropine. Which one of the following statements is true to Stokes-Adam attack? It is usually caused by a high degree of atrioventricular block. The most common cause of sudden arrhythmic death, cardiac death, is myocardial infarction. All the following features favor ventricular tachycardia as the cause of broad complex tachycardia except very broad QRS complex more than 140 millisecond. So which are the features favoring ventricular tachycardia? Fusion beat, extreme left axis deviation, and response to carotid sinus massage. What is the drug of choice to control supraventricular tachycardia? Adenosine. Which one of the following drugs should be avoided in Wolff-Parkinson-White syndrome? Digoxin. Which congenital heart disease is associated with pre-excitation? Epstein's anomaly. In syndrome X, patient have all of the following except abnormal coronary arteriogram. So patient can have angina-like chest pain, ischemic ST segment depression, and excellent prognosis. Which one of the following is the drug of choice in the case of ventricular tachycardia in myocardial infarction? Xylocaine. The ECG of a patient with an artificial pacemaker in the right ventricle shows left bundle branch block with broad QRS complex. The drug of choice for persistent unstable ventricular arrhythmia is amiodarone. Congenital long QT syndrome is associated with neonatal sinus bradycardia. The drug of choice in paroxysmal supraventricular tachycardia is adenosine. Which of the following disease can be associated with short QT interval on ECG? Multiple myeloma. Which of the following treatment is appropriate for tall peaked T waves on ECG? Inhaled salbutamol. A patient develops sudden palpitation with heart rate 150 per minute regular. What could be the cause? PSVT, that is paroxysmal supraventricular tachycardia. Pulse deficit more than 10 is seen in atrial fibrillation. P wave is absent in atrial fibrillation. All are ECG changes in hypokalemia except QT interval prolongation. So the changes which can be there in hypokalemia are U wave, ST segment sagging, T wave flattening or inversion. Hypokalemia ECG changes, depressed ST segment. Athletic syndrome is characterized by increased amplitude of QRS. Tall T wave in ECG occurs in hyperkalemia. Now, cardiomyopathy and pericarditis, 30 to 60 degree left axis deviation, left ventricular hypertrophy. Square root sign is an indication of constrictive pericarditis. Kussmaul sign is most commonly seen in constrictive pericarditis. Beck's triad of cardiac tamponade includes hypotension, neck vein distension, and silent heart. Beck's triad is seen in cardiac tamponade. Topical JVP finding in cardiac tamponade is absent Y descent.